Next up, we'll be hearing from healthcare experts for a comprehensive take on the outcomes-based approach. How is it changing the landscape of patient care, what's working, and what more needs to be done? I'm pleased to welcome on stage Pamela Sutton-Wallace, CEO of the University of Virginia Medical Center, Liz Fowler, Vice President of Global Health Policy at Johnson & Johnson, Patrick Geraghty, CEO GuideWell and Florida Blue, and Cindy Zagieboylo, President and CEO of the National Multiple Sclerosis Society. The Hills Policy Editor Kim Dixon will be leading this conversation. Kim, over to you.
Okay, thank you. So we're going to dig a little more, even more into the weeds from the 3,000-foot level that we had earlier. Talking about pay for performance, accountable care organizations, value, it sounds great on paper, and I know it's been sort of a trend. Everyone wants to get there. But I also know that there are challenges. So our panel has a nice cross-section of manufacturers, providers, patients. Why don't you talk first, Cindy, about the challenges for patients? Because who would say that they don't want value for their healthcare dollar, but it gets pretty complicated for an MS patient, for example.
In multiple sclerosis, it is especially challenging because first of all, value is measured differently. We're very excited to have value measured by patients. That's where it should be measured. The drugs that are on the market right now for multiple sclerosis are really measured based on a couple of FDA approved. You get a drug approved by the FDA because it serves two factors. It reduces relapse rates, and it also improves people's ability to be able to walk, essentially, a particular score. What people with MS value today is they value the ability to think clearly, cognition, and they value the ability to combat fatigue. And these are not measured in the drugs that are approved today. It's just where the science is right now. So it's very difficult to say which therapy it benefits another. MS is a very variable disease, so there is no treatment that is for everybody, that helps everybody. So it's just the science isn't quite ready for this great idea in MS.
So how do you deal with that, Pat, as a provider, this measurement issue, measuring what value means for an MS patient, which is obviously not a monolithic entity?
You know, I think one of the great challenges here is agreement on what data to measure and how are we going to quality assess those that we have in our value-based programs. Our particular approach was, it is not going to be possible to have a perfect system. We're going to have a good system and improve it as we go. And so what that means is having the right dialogues, reaching out to the right partners, continuing to refine the system. But to think that we could have the absolute perfect system at the start, I think was a failed attempt. If you look at the early days of the ACO, where it came out with 64 quality measures, I was in Minnesota at that time. We came out with a value-based deal with 13 measures because we could measure them, because we could see progress, because we knew if we moved the dial on those, we would improve the system. And so I think it's taking a start and enhancing it as you go.
What about pushback from providers? I know this whole drive to value has been portrayed as who could oppose it, but I think that there has been some pushback in terms of, for the very reason that it's hard to measure value. You know, are you measuring the outcome? A provider may give great care and the outcome might not be great or even acceptable.
Sure, and that's why most of the times when we've been in these constructing deals, we do that with focus groups of providers, hospital systems, to help work through what's going to be an agreed upon set of measures that will definitely improve the quality of the patient or the quality of the care that's being given. And we also always believe that patient input is valuable to that process. But you can certainly see what preventive measures have been taken, what therapies have been delivered. You can look at medical records and see the patterns that are there and certainly incent for the right types of behaviors.
From the J&J point of view, Liz, I know you're a medical device manufacturer and a pharmaceutical company. On the device side, you can talk about things that were, as a part of the Affordable Care Act, like somewhat less controversial, I guess, on terms of bundled payments and Medicare. I mean, how is that going? How do you see those things changing under the Trump administration?
Well, speaking as a manufacturer, I think we embrace the movement towards value. We're really excited about it. Johnson & Johnson signed on. We were the first manufacturer, and I believe the only manufacturer to sign on and make a formal commitment towards value under the CMS Learning and Action Network. We think it's the direction the system needs to go. All signs point in that direction, not just from the ACA, but also building on that, the subsequent law MACRA, to change the physician payments. So we think this is the way to go, and we're excited about it. I think this is a bipartisan effort, and I think this point was made before, that there's a lot of interest on both sides of the aisle on trying to do a better job of getting better value for our healthcare dollar. So we're happy to be part of that conversation.
But do you see any policy change in terms of the new administration with Secretary Price?
I think it remains to be seen. We stand ready and willing to work with the new secretary and the new administrator. And, I think, like I said, MACRA, if you look at the physician payment reform law, passed with over 390, or how many votes in the House? 390 some votes in the House and 92 votes in the Senate. So this is the direction the system is going. And we think the new administration will pick up that thread and continue to move forward.
Pam, from your point of view, we talked a little bit last week about how, as a safety net provider, you have very unique challenges. You're also serving a small community where one-size-fits-all measurement might not work. Do you want to talk about those challenges?
Absolutely. So representing the provider side of the house, I think there are some unique challenges and unintended consequences of the value proposition. I think we all agree that value is key, and we can't continue the cost curve that we're currently on. However, in my institution alone, we measure 484 measures for 11 agencies. And of those 11 agencies, 8 of them measure mortality in different ways. And you would think a death is a death. But in fact, it is calculated different. It's risk adjusted differently. We spend about $13 million per year just capturing measurements. And so one could argue that that's an administrative burden in our organization, that those dollars could be redeployed for healthcare utilization. I think the other unintended consequence as we begin measuring quality is thinking about the role of social determinants of health. And what are the roles of education, nutrition, transportation, needs that typically aren't met by healthcare providers in this space. And the good news is it's encouraging innovative collaborations between social services. The challenge is there's just not enough money to go around. And when you look at healthcare outcomes, they are more influenced by those social determinants than they ever are by clinical care determinants.
I mean, I know, Liz, you talked about this being a bipartisan issue, but there are elements in the Affordable Care Act that, incent providers to do this measurement, et cetera. I mean, how do you see it playing out? I know there is some opposition on sort of the mandatory nature of some of the things at CMS. Can all of you talk about how worried you are or what you see the Republican effort doing on this value front?
Well, I think Pat raised some really important points about whether or not we're measuring value in the right way and whether or not we're measuring it consistently across payers. And certainly there's more work to be done, but I think we're at the beginning of this journey, not the end of the journey, and really there's a lot more to be done in terms of figuring out how best to measure quality, how best to measure outcomes, how to consider the patient perspective in doing so. I think there's a lot of work for this new administration to do and may have a different perspective on some of these issues. And, hopefully we're, continuing to move in the direction and refining our approach as we go on.
We began our journey down this value-based path in real seriousness about 5 years ago. Today we have over 1.5 million people in Florida that are in value-based arrangements. When we started down this process, people said, that's not going to happen in Florida. That's not the way we do things. We have 25 ACO arrangements in Florida today. And so what we have seen is some clear improvement. We have about 4.5% lower cost if someone's in an ACO than if they're not. So that's been a very significant moving of the dial. So we're committed to that on the private sector side. We're committed to the creativity we've created, the partnership we've created with the organizations that we're working with. And it's always helpful if Medicare is coming along, because then you've got the law of large numbers, you've got people moving in the same direction, you have less confusion around what the reimbursement models look like, not to mention the quality data models. So when you have that confluence of players acting in the same way, it's helpful. But it's a movement that is not going to go back. It's not going to retreat because we cannot afford to be in a fee-for-service world. I think that those days are gone. The question is, what pace are we going to have as we move into the future? The administration could help that pace. It's yet to be seen if that's where they're going to come down.
What's being done to coordinate these, what you mentioned about like several different ways to measure death? I mean, is something being coordinated on a payer level, on a, I'm not sure what level it would be on, to get everyone on the same page to measure something as basic as that and beyond?
I think it's a good question. I think we're seeing collaboratives, at least in the Commonwealth of Virginia, a group of payers, providers, dentistry, believe it or not, other organizations are coming together to try to say, the Department of Health are trying to really streamline what are those measures that are important for patients. And I think that's a critical difference, right? What are not just the process measures, but what are the outcomes measures? Are we really improving someone's health? Not just are we measuring the processes to improving health? And those are important conversations, trying to narrow the focus of specific outcomes. I do think the challenge will be how to address these in different markets, right? So when we talk about value, and I always tell people, you got to be clear, what are we talking about when we say value-based programs? There's everything from a accountable care organization all the way to kind of full risk models to pay for performance models. And all of those are very different, and they incent different behaviors. And when you live in different markets, and one could argue, for example, the market of Charlottesville is still fairly rural. It's very hard to spread risk over that population. And so what we find is people start cherry picking or skimming which patients they will care for. And I dare say if you start asking certain providers, how many people are still taking Medicare, Medicaid patients? That number is dwindling in key markets. And all of us have heard about the small rural hospital that is often a critical access hospital who are closing their doors because they can no longer afford to care for the sick of the sick. And so these are going to be very important questions as more and more patients cannot receive health care in their local marketplaces. And I think that's a dialogue.
A few things, yeah, that I think one thing that we must keep in mind is that there's not going to be ever one size fits all. There might be some categories of disease or illness that people have that we could do this very well, a value-based market. There are other factors that make some diseases like multiple sclerosis not ready. The science is not ready to have a pathway for treatment of a person with multiple sclerosis. It's just not there yet. We don't have that yet. You talked about measuring and determining what value is. Really the patient needs to be in the front, in the very front. And we see this now that we have treatments for multiple sclerosis and more people are working and they stay in work, they care about being able to think well.
That's right.
And when we start imposing and making restrictions in terms of what therapies are going to be available, then we are delaying treatment to people, which means that they're getting worse. A relapse in multiple sclerosis means that you've damaged, the brain is damaged. And so the more you delay options for people with multiple sclerosis in particular, the sicker they're going to get.
I think Cynthia is right in defining functional well-being is just as important as curative well-being, right? So are you able to work? Are you able to continue to be productive? How is your mental health? Those outcomes are just as important as some of those process measures that we talked about earlier.
I would argue more important.
But I agree with you.
And I think from our perspective, we would agree as well. I think the pharmaceutical industry would very much appreciate having the patient perspective be part of it. It's not just about sort of a short-term cost savings, but really looking at the bigger picture, the longer term, and also considering the patient perspective.
But how are patients part of it now? Like in an accountable care organization that you have, Pat, I mean, Do patients get questionnaires
Absolutely.
along the way?
Yeah, patients are asked for their feedback throughout the process, and every year they're asked in general, even if they haven't had care. But when people have care, they are surveyed for their sense of the treatment that they got, where they are on their functional recovery, how do they feel about where they're headed. So we do survey all the time. That's really important. One other point I wanted to make is we've also organized within our organization in an organization called PODS, so it's a place of delivery setup, which means for us that instead of just being aligned sort of functionally around one grouping or another, we have clinicians who work in a geography across disciplines. Because what we find is sometimes we're dealing with what looks like a physical ailment and it turns out to be a mental health issue. And if you're only dealing with physical clinicians, you miss this mental health issue. And so it's very important to be connecting those dots and to have somebody who's thinking about what's the whole patient view look like. And I think that's a new way of thinking about how we're organized to work with the system, work with patients, and we're seeing some early progress in that area.
You know, one issue that came up in the previous discussion is on some of the regulatory barriers that stand in the way of this. And as we're trying to move from a fee-for-service system towards one that rewards value and appreciates value, we need to really take a look at the regulatory and the payment structures and make sure that these new arrangements can be accommodated. And I think right now we haven't reached that point. From our perspective, we see a lot of barriers to moving in this direction in terms of what we can share, what information we can share with payers about what works and what doesn't, about some of the Medicaid best price, for example, which price counts, at least in the pharmaceutical perspective, if something works or doesn't work. So we're hoping that as part of this conversation, we can revisit the regulatory framework that really was built around a fee-for-service chassis and see if we can reform that along with trying to move in this direction.
Are those all things that could be reformed on the regulatory side, or would they need to go through Congress?
Probably some of both, a little from column A and a little from column B. But certainly need to step back and take a look. And it's not just our industry that's going to face this issue. It's also from the payer perspective, from the provider perspective. I'm sure you've run into a lot of, as these arrangements are coming on board, you start thinking about, well, is this going to look like some sort of kickback or some sort of payment that doesn't set right with the current structure? So I think all of us need to be part of that conversation.
And I do know Secretary Verma has started some of those conversations, or Administrator Verma, in terms of what are some of the administrative burdens. For example, as you're implying the HIPAA privacy rules and Stark regulations, especially as we go into these value-based models where hospitals and physicians and long-term care facilities, SNFs, have to coordinate care. It's very difficult to share information. It's very difficult to share resources without violating some of those more stringent rules.
The cost of care and of treatments is just there are so many complexities to this. In MS, the pharmaceuticals, the drugs are the largest cost. And the challenges we have with those, the prices keep going up until most recently, with the most recent drug, it did come down a little bit, so there's some movement in this whole area. But it's unclear what influences all those costs. So we need it to be more transparent. We need what's available and what you're paying for to be simple to understand. And we need it to be transparent. And of course, we need it to be affordable. But these things, because there's so many invisible pieces of it, it's very hard to take it apart.
Now, I don't know if J&J makes MS drugs, but what is J&J doing on transparency, Liz?
So we're not in this space, so I can't speak to those issues in particular. But what we've done, and if you look on our website, we put out a transparency report at the end of February where we talked about how we make pricing decisions, how we think about pricing pharmaceuticals, how we think about value, what goes into pricing pharmaceuticals. We think about value. We think about what the value and benefit of that new product will be when a drug is launched versus the standard of care. we think about access and affordability and how payers will view these products when they come into the market versus what is available today. And also think about innovation and future innovation, of course. The report also goes into a number of other areas and initiatives we've undertaken at Johnson & Johnson, the pharmaceutical company of Johnson & Johnson. We've made all of our clinical trial data available through Yale, so any researcher can access that data
Even
and
negative
submit a
trials?
request.
Even negative trials?
All of our data is available. And so we also document how many requests have come in, what has been granted. And we've also set up a program through NYU, through the bioethics department on compassionate use. So when patients come to us and look for a product that hasn't been approved yet, what's the process and what's the standard for getting access to some of those products that haven't been approved yet. So it's a comprehensive report. I will say also looks at the difference between list price and net price and what goes into the pharmaceutical supply chain, which I think are issues that are coming to the forefront now. And we think there's a conversation worth having there and worth discussing. So would encourage everyone to go look at the report.
The price of the pharmaceutical company sets for a drug is not necessarily related to what a patient pays. And that's a big part of the problem. There are lots of pieces. So the transparency that you
Exactly.
describe is a step, and there's more needed.
Right, although the idea is that the insurance company will have some leverage because they're representing, it'll be cheaper if I have insurance because there's a,
It depends on which insurance.
right,
is.
rather
And
than.
that's a moving target.
Yeah.
Well, we obviously are all in favor of the transparency in this space, and Johnson & Johnson's been a good player, but there have been others that haven't been such good players, and probably some pretty clear examples like EpiPen and others that were out there that just were raising prices without regard. And so those are the areas where we think there's more focus and attention that needs to be put in place.
Well, and let me say one thing, that value is not going to solve the Shrellies of the world, and it's not going to solve the problems that we see that are real abuses of this system. I mean, what we're talking about, the conversation here, we're talking about the innovative pharmaceutical industry.
But those are extreme examples, and there are expensive, life-saving drugs made by reputable pharmaceutical companies that still cost double, the price of a car or more.
And we want those drugs, those products to be used for the right patient at the right time, and we want them to work. And if they don't, and there's a way to measure that, then we want the system to account for that. I think that's what this conversation is really about.
We'll take some questions in a minute or so. If people want to start raising their hands, I think we have people walking around talking about value. Anything related to the ACA or the AHCA? Okay, we can keep going then. So I was in Europe for a while, and pharmaceutical companies were negotiating directly with countries, payers, and can you talk about the agreements that you have with certain payers? I mean, do you have, for Sovaldi is not the drug that you, but if you can prove that you reduce hospital stay for X amount of days over the long term, I mean, are you having those kind of contracts with insurers?
Absolutely. We have a lot more of those contracts in place overseas, and particularly in Europe, and that's because they don't have the regulatory barriers that we have here. And I think that's exactly the conversation that we'd like to have, is we think there's more to do in this space. And I will say, and this is a conversation, everyone says, well, why are they paying less? Why are we paying more? I think it's the wrong question to ask, because these systems are different, and we're operating in a completely different system where the rules are different, the access is different, the way that they're set up, even the way that patients respond, I think, to provider input is different. Just looking at what's available in other countries too, in countries that people point to and say, that's, why can't we do things more like this? Looking at the UK, for example, they weren't approving and don't have access to a lot of the oncology products that we do here, and had to set up a separate fund to get access. So as we look at other countries and say, oh, I'd like to live there, I'm not sure if we take a deeper look that might not be the case.
But are there certain models? I mean, obviously, every country is different, but is there a model of another country that you think the U.S. might move towards?
Well, and remember, I worked on the ACA in my previous role, working with the Senate Finance Committee, and a lot of people said, why don't we look at other countries when we're reforming the U.S. healthcare system? And I think the truth of the matter is we have a pretty unique system here. I don't know that anyone would look at replicating our system elsewhere, but I also think it's really hard to draw examples and say, well, let's take that and bring it here. And it was really, there wasn't a lot of interest in saying, well, let's take Switzerland or the Netherlands, which are two that people point to and say, well, they've got a private insurance aspect. Let's try to bring that here. These are really small countries that are very homogeneous, not as many rural issues. I mean, if you think about the complexity of the U.S. population and the U.S. system with the interchange between the states and the federal government, it just isn't so easy to say, let's bring that over here.
Right, they're more likely to have registries, they're more likely to, really have less privacy issues that they have right there. But the movement that we're making now to care about what people think, not that somebody else is telling you what your quality of life is. I'm telling you what my quality of life needs to be. That is a big movement, and this will help. And we just have a lot of things to sort out, which you've described, but that having those values clear, I think will help us make the right decisions moving forward and learn from others as well.
I don't think there's a system we could just plunk down in the U.S. and it would work here, but we can learn some lessons. And I did a delegation trip to Germany to look at their system. And one of the really interesting questions that was asked very early in the trip was by the minister in charge of drugs for Germany. And his question was, why do you advertise? Why do you allow advertising? That was their first out question.
Anywhere else, really.
They thought it was shocking that we allowed advertising, and if you look at U.S. spending, when advertising started, the spending went through the roof. So it's an interesting question.
Yeah.
I think other interesting questions that we can learn from other countries are the cultural norms around end-of-life care and palliative care. And some of the earlier statistics that were quoted is that you have 5% of the spend, or 5% of the population is using 58% of the spend. You could also say 20% of the population is using 80% of the spend, and often that spend comes at the end of life. And we have extraordinary expectations in the United States about end-of-life care, rescue, when really it's futility of care. And other countries have really curtailed some of that. And you can argue one way or the other, the benefits, the pros and cons of that. But I think it is a tough issue we're going to have to grapple with over the next few years.
Throw it open for questions again.
Hi, I'm Daniel from Research America. First of all, I'd like to thank you all for your insights. I'd like to ask each of you to offer perhaps any insights of your own as the senators are writing the healthcare bill.
Yeah, that one's right in my wheelhouse. So, let me make a so first of all, I would say they need to fund the cost share reduction. That is the first and primary thing to take all the instability and question mark around that out of play. Let me give you a clear example on that. My company needs to file our rates for next year in a week. And right now, we don't know if the cost share reduction is going to be in or out for next year. So what we will do is we're going to file one rate, and then we'll have a footnote that says, if we don't have a cost share reduction guaranteed by September, that our rates will be, on average, 20% higher. 20% higher, because we've actuarially mapped it, and that's what we know will happen in our population. We in Florida, Florida Blue, cover almost 900,000 people in our individual market. We've been very successful. We've operated in the black. But this particular policy question is the most important one that needs to be answered. The House punted on it. It's now in the Senate. Will the Senate take it on? And if not, what will the White House do if it's left for them to decide on? And clearly, the timeline in Washington doesn't meet the timeline that has to be met in the marketplace.
I would contend that it is not okay for 24 million Americans to no longer have health care coverage. That is not okay, and any solution needs to be based on how do you retain coverage and ideally enhance coverage for those individuals. That's an extraordinary number of people. Even in, again, states that did not expand, many people bought on the federal exchanges. And so stabilizing those exchanges, I think, is critical.
I agree with what you just said. And we've already, I think everyone agrees that we have to have pre-existing conditions have to be covered. I think another thing that can get in the way of what you just said is this idea that you get something that maybe doesn't necessarily called, but it looks an awful lot like a high-risk pool, where you skim off people and put them the most expensive diseases in a particular category, and then they're left to fend for themselves, which essentially is taking their insurance away. So I think that's another big thing we have to make sure we keep our eye on.
And I would say, I think the most frustrating thing for me watching this debate, sad and frustrating, is how partisan, how polarized the environment has become. It has become black and white. You're either pro or you're against. And I think some of the rhetoric that this has been a total disaster and that the system is falling apart is absolutely false. I think there are issues, there are clear issues that need to be addressed, cost sharing subsidies, for example. But it's not the case that we're in a death spiral. There are 20 million people that have gained coverage. Our uninsurance rate is the lowest it's ever been in this country, at 8.8%, which is less than 16% before the coverage expansions began. So it's not a total disaster, but on the other hand, it's not perfect either. If we can set aside this partisanship and not look at everything as black and white and really try to come together. And I didn't hear that this morning, and look, I have been there, I've seen that. But it's just unfortunate that we can't set aside those differences and try to work together to solve the problems.
So if I could follow on the point, to your point, the cost share reduction in my state makes a huge difference at keeping people covered. 1.2 million Floridians out of 1.6 million that are covered are benefiting from the cost share reduction. Very price sensitive market. These folks are unlikely to be covered if they lose the cost share reduction, so that's critical. To the point about pre-existing condition, we as an insured don't want to deal with pre-existing condition. We want everyone to be covered. But in order to do that, you have to have everybody in the market. And so the reason to have an individual mandate was to try and move towards having everyone in the market in the first place. If we're going to say the individual mandate doesn't stand, then we have to have something to replace it. Something around continuous coverage, something that puts in the marketplace a check against somebody signing up for coverage right before they have a surgery, dropping coverage right after they have a surgery. I think we can all see that mathematically that doesn't work. You can't have a market if people can come and go as they need care. Who's going to pay for the balance, right? So we've got to have some measures in to stabilize that marketplace. Individual mandate was one we thought could work and support pre-existing condition being taken care of. But if you're going to change that, you've got to have a policy that is really capable of keeping the market together and stable.
All right, we'll be looking for what the Senate bill attempts to do on that front. We're out of time. So thank you all. Thanks to the panel. Thanks to the audience.
Thanks. I'm really sorry I called you Pat instead of Thank you. That's bad.
Us to the end of our program. On behalf of the Hill and our sponsor, the Value Collaborative, an initiative of America's biopharmaceutical companies, I'd like to thank all of you here as well as watching the live stream. The full video of the event will be up later today. And as a reminder, there are surveys on your chairs. We'd love your feedback. Feel free to give them to a member of the Hill staff. Thanks so much. Have a great rest of your day.